Bismillahirrahmanirrahim. Now we are looking at amenorrhea, mean no menses. So there are two causes, either it would be a primary or secondary. So when a woman complains, why I'm not menstruating, it's mean amenorrhea. So it's if it's a primary, mean no menses at all. Uh, she has not a single mens. Primary menses mean no menses start. The female reach at the young lady reach at 16 year, and she has a secondary sexual character. Mean she has developed breast, pubic hair, but no menses. So it's considered as amenorrhea, primary amenorrhea. If she is reached at 14 year without secondary sexual character, then it's also considered as the amenorrhea. It's a primary amenorrhea. What is secondary? Secondary means she started menses, but later on she stopped menses in reproductive age and not a menopause age. So it's considered as a secondary amenorrhea. So how we can confirm if there are more than 3 regular cycle missed or more than 6 months in irregular cycle, then it's considered as a secondary amenorrhea. Okay, so there are some physiological causes. Physiology mean she is before puberty or after menarche when she start menses, but sometime one or two menses she may miss. But if it's more than three, then it's considered secondary. Otherwise, it's a normal. During pregnancy, during lactation, and there is no menses. After the menopause, mean after the reproductive age, mean during a menopause, it's a physiological. But if in other problem, it's a pathological. Either it's a primary or secondary. So first look at the picture. What is happening in the maturation? There are four compartments actually: hypothalamus, inferior pituitary, the ovary, or the this reproductive tract. So where you see the uterus, cervix, the vagina, and here is the hymen. So, okay. So these are four compartments. Compartment one, two, three, four. So what is happening in the normal maturation? Hypothalamus secrete GnRH, which stimulate the anterior pituitary, which release the FSH and LH, which stimulate the ovary, and it produce estrogen and progesterone. Estrogen and progesterone actually act on cause the release of there is a release of the egg, and estrogen progesterone stimulate the uterus, and this lead to development of endometrium development, and this finally after 1 month, if there is no pregnancy, so there is loss of the arteries in the present in the endometrium. This lead to menstruation. Okay, so there are two causes of menstruation. Okay. So in this compartment also there are two cases. Either it's absent secondary sexual character when there is no estrogen. Mean when there is absent secondary sexual character, mean there is no estrogen for the development of breast and other the men, so another important role of estrogen is the development of secondary sexual characteristic. If there is problem in this the upper three compartment, mean hypothalamus, anterior pituitary, or ovary, then there are no sexual secondary sexual development. Okay, so mean there is no estrogen. So this is considered as the anovulatory. Okay, and if there is presence of secondary sexual characteristic, mean breast is developed, so then it's mean there is enough adequate estrogen is present. Okay, so this is called anovulatory amenorrhea, and this is considered as the ovulatory amenorrhea. Mean there is no problem in the ovulation. The problem is in the tract. Okay, the outflow tract is if obstructed or any abnormality, and then it's considered ovulatory amenorrhea. And if the outflow tract is obstructed, so this is known as cryptomenorrhea, and anovulatory amenorrhea, ovulatory amenorrhea, and cryptomenorrhea. Okay, we have two causes. Either it would be a primary case or it would be a secondary. Primary mean no menses start reaches at 16 year. So let's look at hypothalamus. What is problem would be in the hypothalamus? Number one is the Kalman syndrome. Kalman syndrome, which is also associated with the insomnia, mean she's not smelling anything. So Kalman syndrome is actually a hereditary inherited problem. What is happening where no GnRH neuron are reaching at hypothalamus, and these are also important for the olfactory epithelium, which is for the sense of smell. So if in this inherited disorder, what is happening? Two thing problem. I mean, hypothalamus will not work properly and impair function of the this sense of smell. Okay, so this is Kalman syndrome. Now if you look at the ovary, there will be the most important cause is the Turner syndrome. Okay, 450 X naught. Okay, when there is this is the congenital abnormality. Okay, Turner syndrome, chromosomal abnormality. So it is the commonest cause of the primary amenorrhea. Okay, if you look at the in the outflow tract, so number one, if you look at uterus, there would be a problem. Mean uterus, there is age androgen insensitivity syndrome. Okay, which is again a genital problem, and other is Mullerian agenesis when there is no development of uterus. In both condition, the androgen insensitivity syndrome or Mullerian agenesis, there is no uterus development. So that's why there will be no menstruation. So the if you look at their karyotype, it's a 46XY. XY mean it's a male type. Okay, so in this case there will be a high level of the testosterone, and other thing you will in this case the testosterone level will be normal, but in this case there will be a pubic hair development and there will be no pubic hair development. Okay, so this is the these are two conditions, the androgen insensitivity syndrome and Mullerian agenesis. Okay, this is second most common cause and this is the third most common cause. If you look at the outflow tract, mean the cervix and vagina level. So number one is there is agenesis, cervical agenesis, or the vaginal atresia. Okay, so if there is agenesis or atresia of cervix and vagina, it's a problem. So that's when she is not menstruating. Other cause is transvaginal septum. Transvaginal septum, there is a septum in the vagina which do not allow the menstruation. And the third cause is the imperforate hymen. Hymen mean this is a hymen, a membrane which is covering the outflow. Okay, if it's imperforate, then there will be no menstruation. Okay, there are four compartments: Kalman syndrome in the hypothalamus, Turner syndrome which affecting the ovary, and the androgen insensitivity syndrome or Mullerian agenesis. So they are affecting the uterus, mean there is no uterus development. And if there is atresia of cervix and vagina, transvaginal septum, imperforate hymen. So these are the primary cause. If you look at the secondary, so most common cause is a pregnancy. So first you should rule out the pregnancy. Okay. Or another thing, then there is an endocrine disorder. Endocrine disorder means there is the thyroid disorder, for example, the hyper and hypothyroidism, and uncontrolled diabetes, the adrenal disease, for example, congenital adrenal hyperplasia, Cushing syndrome. So they can cause the amenorrhea. Okay, and if you look at the hypothalamus, so first thing you should after the pregnancy you should ask for the drugs. Okay, if she is taking contraceptive drug or anti psychotic drugs, so it will lead to amenorrhea. Okay, or she is psychological. For example, she is in a stress, so this cause the amenorrhea, or she is severe weight loss. She's or excessively exercising. So this may cause the amenorrhea. Okay, and if you look at the anterior pituitary, so number one cause is the Sheehan syndrome. Sheehan syndrome, it's a syndrome which actually damage the pituitary after postpartum hemorrhage. If there is severe postpartum hemorrhage, so there will be ischemia to the anterior pituitary, which causes damage of the anterior pituitary. So this is known as Sheehan syndrome. The next cause is the empty cellular syndrome. Mean there is no the pituitary is present in their position. Okay, if there is absence of anterior pituitary or it's a damaged anterior pituitary, so this is empty cellular syndrome. The next is prolactinoma. Mean there is a tumor of the prolactin. So this either would be a micro, mean less than 1 centimeter, or it would be a macro, which is more than 1 centimeter. So this causes the amenorrhea. If you look at the ovary, the number most common cause in the ovary is the PCO, in polycystic ovarian disease. Okay, polycystic ovarian disease. Okay, and there would be a the premature ovary insufficiency. Premature ovary insufficiency mean the eggs has been exhausted prematurely. Mean normally there are some eggs are exhausting in the normal physiological period, but sometime due to some autoimmune disease or there is some congenital problem, so this may lead to exhaust a number of ovaries. Mean there is no ovary present in there is no egg present in the ovary, which lead to premature menopause. Okay, so this is another cause. If you look at the outflow tract, the most common cause in the outflow tract is the endometrium. Sometime if there is a problem in the in this tract, female reproductive tract, so they undergo some surgical process. For example, in the polycystic ovarian syndrome or in the endometriosis, so they remove some endometrium. If they completely remove this endometrium, so this is known as Esterman syndrome. Esterman syndrome mean after the curettage there is complete there is excessive removal of the endometrium. So this will lead to the adhesion between these two walls. Okay, so there is adhesion at this level. Okay, so this causes the amenorrhea. Okay, so drugs and psychology, first pregnancy, endocrinal disorder. In the hypothalamus, there would be a drugs, psychological problem, Sheehan syndrome, empty cellular syndrome, prolactinoma, PCO, or premature ovarian insufficiency, or there is a Esterman syndrome. So how you should approach this patient of amenorrhea? So first of all, take detailed history, etiology, rule out first drugs, primary causes and the secondary causes, and then look for if there is a postpartum hemorrhage or if there is dilatation or curettage process. So take history of that. Okay. And then go for the clinical examination. In the clinical examination, look for secondary sexual character and the local. Okay, how you should diagnose it? If there is secondary amenorrhea plus secondary sex or sexual character are developed. Okay, so then go for ultrasound. If in the ultrasound you see the uterus, mean there is outflow obstructed. Okay, if you do not see the uterus, mean there is these two problems, the androgen insufficiency syndrome or Mullerian agenesis. Okay, so how you can confirm? By looking at the karyotype defines you XY or XX. XY is the AIS and the XX is the Mullerian agenesis. Okay, and in the if there is no second, it's a primary amenorrhea and no secondary sexual development. Look for FSH and LH. If there is high FSH, or if there is low FSH, if there is a high FSH, mean it would be a Turner syndrome. Okay, or other congenital problem. For example, agonadism. Mean there is no there is agenesis of gonads. Okay, or if there is a low FSH, mean it's defined there is a hypothalamic problem. Okay, so look for the other test TSH and ACTH. This to confirm either it's not the hyper or hypothyroid problem or any adrenal problem. Okay, and if there is a normal FSH, So this define this it would be due to PCO, mean polycystic ovarian syndrome. Okay, and other you can go for laparoscopy and hysteroscopy to see the internal picture of the this track. Okay, treat the etiology. Underlying etiology, if it's removed, then it will be normal. Or we give them initially medical therapy, for example, hormone replacement therapy, which is most commonly used. And if it's not improved, then go for surgical process. Okay.
How we clinically approach the primary amenorrhea? Okay, first take the history to confirm it's a primary, mean no menses started 16-year plus secondary sexual characteristic, or 14-year without secondary sexual characteristic. Then you go for the FSH, LH, prolactin, TSH, and ultrasound. Why? If there is abnormal TSH level, mean the problem is the thyroid. So there is thyroid is hyper or hypothyroidism. Okay. If there is a high prolactin, low FSH and LH, so mean there is considerable adenoma. So okay, so you go for the MRI to confirm it's adenoma, for example, prolactinoma, and then you also check out their size. It's a micro or macro. Okay. In ultrasound, what you see you see the uterus. Uterus is present or not? If the uterus is present, yes. If not, no. So if the uterus is present, go for the progesterone challenge test. Progesterone challenge test defines if she starts bleeding, so it's an ovulation. Okay. If she not bleed, give the progesterone and estrogen. Okay. Meaning if she start bleeding, mean ovarian failure. If she is not still menstruating, so you think of the outflow tract obstruction and hypothalamus pituitary axis problem. Okay, so how you can differentiate outflow or hypothalamus? By FSH test. If the FSH is normal, so it's an outflow obstruction. Okay, if the low FSH, mean there is a hypothalamus and pituitary problem. So if you see the other symptom, for example, insomnia, mean there is the Kalman syndrome. So how you can differentiate hypothalamus or pituitary? By looking at MRI. If MRI is normal, so mean there is a hypothalamus problem. If MRI is abnormal, mean there is a pituitary problem. Okay. So if there is pituitary problem, if you give a GnRH, so there will be no effect of GnRH because pituitary is not responding. If there is problem in the hypothalamus, okay, so if you give the GnRH, so pituitary will increase the FSH level. Okay, so that's why if the GnRH test is positive, mean FSH is increasing, mean the problem is in the hypothalamus. Okay, pituitary is normally working. Okay, so if the FSH is high, it also define the primary ovarian insufficiency. Primary ovarian insufficiency, go for the karyotype. So look for the karyotype, either it's the Turner syndrome or agonadism. Okay, for example, in the severe syndrome, 46XY or 45X0. Okay. On the other side, what you see, uterus is absent. You check the breast is present or absent. If the breast is present, mean there is MRKH, or you can say the Mullerian agenesis or androgen insensitivity syndrome. Okay, if the breast is absent, mean there is agonadism or enzymatic deficiency. Okay, if the this case go for the karyotype, and by looking at karyotype 46XX, mean there is MRKH or Mullerian agenesis, or 46XY, then it's an androgen insensitivity syndrome. There will be, you do not see the pubic hair. In this case, you will see the pubic hair. Okay, on this case, agonadism or enzymatic deficiency, by looking at karyotype. In both cases, karyotype is 46. How you can differentiate? By looking at the HCG stimulation. If there is agonadism, it will not respond to HCG. If there is enzymatic deficiency, there is somehow testosterone level will be increased. In this case, the unchanged testosterone define the agonadism. Okay, so in this way you approach the primary amenorrhea. How we clinically approach the secondary amenorrhea? So it's quite similar to primary amenorrhea, but you should confirm by history and examination it's a secondary or primary. Okay, then you go for investigation, similar FSH, LH, prolactin, TSH, but here instead of ultrasound, you go for the pregnancy test. Okay, TSA define the thyroid disease, and the prolactin FSH define the adenoma. Okay, micro by MRI. Okay, and pregnancy test. First thing first is a pregnancy, most common cause. Okay, if the pregnancy is positive, it's okay. If it's a negative, no pregnancy, then you go for further investigation. For example, progesterone challenge test will define the anovulation. The anovulation most common cause is the polycystic ovarian syndrome, where you see the normal FSH but high LH level. Okay, and there would be ovarian tumor where you see the mass, and if there is adrenal disease, for example, Cushing syndrome or the congenital adrenal hyperplasia, so you will see in the other symptom also. Okay, and if this is negative progesterone, then give the progesterone and estrogen. If it's again negative, mean it's a Asherman syndrome or outflow tract obstruction. So how you can confirm? By hysteroscope. Okay. And if it's a positive, mean she start bleeding. Okay, after the progesterone, estrogen, mean there is the ovarian insufficiency or there is a hypothalamic pituitary. How you can differentiate? By looking at FSH level. So if it's a low or normal FSH, mean hypothalamus or pituitary. If it's a high FSH, mean primary ovarian insufficiency. To rule out whether it's a hypothalamus or the pituitary, go for MRI. Normal, it's a hypothalamic. Abnormal, it's a pituitary. And if the hypothalamic problem, so pituitary is normal, so it will respond. So that's why in the hypothalamus problem, GnRH stimulation will positive, mean FSH level will be high. Okay. In the if there is primary ovarian insufficiency, go for karyotype, especially if it's under 30, because there is chances of the underdeveloped the gonads present, which may lead to malignancy. Okay. Okay. So this is the clinical approach of the secondary amenorrhea. Okay. So these are causes of secondary and primary, and here the diagnostic approach. Thank you very much. This is all about the amenorrhea.